Lawin Media Network,
bringing to you the most relevant content across all platforms.
Business, legal, politics, health, lifestyle, and entertainment.
Your source for all the news and updates in the greater Houston community from Texas and all over the world.
Get informed and empowered with Lawin Media Network.
Good evening, everybody, and welcome to Pink Table Talk. I'm your host, Dr. Carly D., a doctorally prepared nurse, educator, mentor, professional development specialist, victims advocate, and thriver. The show is produced by Lawin Media Network, and you can catch us live every Wednesday night at 7 o'clock Central, 8 o'clock Eastern, either through our YouTube live channel, Facebook Live, Twitch TV, and on all podcast platforms. Tonight, we're going to be discussing a very important issue that has been plaguing Texas for some time. We're going to talk about the current state of health here in Texas. Most recently, a nurse was fired for how she mistreated a patient in labor. We're going to look at the clip of what happened to this patient.
Y'all treat all your patients like this or just the Black ones?
This is Dallas Regional Medical Hospital in Mesquite, Texas. This isn't the first time that they have been subject to controversy in viral videos online, criticizing them for patient care because of that nurse in this video. This is LaCrista Vaughn, the nurse from that video, and she was featured in another prior viral video. A young Black man with a seizure condition came into the emergency room and was treated poorly because they assumed that he was on drugs.
Go ahead and turn your phone off too, please. I can record. I'm in a public place.
That's fine. That's fine. All right.
Yeah, look at the treatment.
In this video, this patient was in active labor, and this nurse showed absolutely zero care and concern for her. Instead, she was more concerned with filling out paperwork than actually getting her up to labor and delivery or helping her at all. The person recording the video was the patient's mother. She has since posted a follow-up video explaining the entire story, where she states that her daughter had actually been scheduled for an induction that day, and they called and told her that they didn't have enough beds and they would call her when one was available. She went into active labor later in the day. It says that they even called ahead of time to let the hospital know that they were coming. But by the time that they arrived at the hospital, she was already in active labor and the baby was born 12 minutes later. As the patient is sitting here screaming because of the agonizing contractions, the nurse keeps asking her questions, to which she or her mother responds. But by the time she gets on the phone to actually speak to labor and delivery, she's acting like she doesn't know the answers to the questions that she was just given.
Her due date is the 10th.
This is not an isolated incident for this nurse or this hospital, because apparently they have a reputation for this sort of thing. I'm going to tag the OG poster down below. Please go watch all of their videos, repost, do all of the things, because this nurse needs to be held accountable.
So tonight, joining us to continue this discussion about the current healthcare state in Texas is Serena Tobar, a PhD candidate at Texas Women's University. She's also a legal nurse consultant, and she was a former board of directors member for Texas Nurse Association District 9. So everybody, welcome back to the show, Serena Tobar. Welcome, Serena. Thank you so much for joining us tonight.
Thank you for having me. It's a very important discussion that we're going to have.
Yes, it is. And so I know that you have seen this video. So first of all, let's talk about it. Tell me, what are your thoughts about this situation?
I think that when you're looking at the video, and again, we don't know what all was going on behind the scenes, but there just doesn't seem to be any sense of urgency. And we know this woman is pregnant. She's term. She's in labor. She's in pain. And, you know, there needed to be some sense of urgency because, number one, the ER is not the experts in delivering babies. And so we don't know. There was obviously no assessment done. Is this baby even crowning right now? So definitely there was no sense of urgency. And definitely you can tell the mother was in some kind of distress. So number one, is the baby crowning? Is it an imminent delivery? Is there something wrong with the baby? Could there be placenta previa? Could there be cord prolapse? Could there be something going on? And we wouldn't know that until we got an assessment done.
Correct. And no fetal monitoring. You know, there was no device put on the patient to monitor the fetus's heart rate or vitals. So we don't know how the baby was doing at that time. So that was a very dangerous situation, not only for the mother, but also for the baby.
And we know the literature shows it, the research has shown it, that Black mothers, Black women have higher incidences of maternal mortality. It is not an opinion. It is a researchable, reproducible fact through research.
Correct. And I myself have been working in research in this area since 2019 after my own two experiences dealing with preeclampsia, where I almost lost my life twice, and my children almost lost their life twice. Both of them were born prematurely. The first one was 4 pounds. They told me, oh, you would never develop preeclampsia again. And then I did with the second pregnancy, and she was born even earlier at 32 weeks, and she was 3 pounds. And so both of them had to stay in the NICU. I had to be put on emergency medications. And the second pregnancy, I bled out. They had to revive me and transfuse me. You know, it was a very awful experience. And it robbed me of that maternal experience, that sense of, you know, the joy that comes with motherhood, you know, having your baby even in your room with you. I didn't get to experience that. And a lot of it was due to poor prenatal care. I wasn't able to get the right care that I needed. And a lot of my symptoms were ignored. If it wasn't for my own healthcare knowledge, I was monitoring my own blood pressures. You know, I'm doing my own pressures and calling the doctor like, hey, what should I do about this pressure? And he's like, oh, you're fine. I said, no, something just isn't right, you know? And so to me, as somebody who is in healthcare, can experience such an awful experience, I can only imagine what those without any healthcare knowledge are experiencing.
Exactly. And they don't know who to turn to. They don't know how to advocate for themselves. They get frustrated. They give up. They quit seeking medical care until it's at that very, very emergent stage, because nobody listens to them. Why should they go? Why should they go to their primary doctor? Their primary doctor doesn't listen to them. Why should they go and get prenatal care when they go to the OBGYN and the OBGYN is dismissing their symptoms? So it's just why bother, right? And so then it end up in an emergent situation in an emergency room, and still they are dismissed.
Correct. And it's so funny because a lot of people think that this is a new phenomenon. However, my own delivery as a baby that my mom experienced was similar to what this patient experienced. When she was giving birth to me, her water broke. She lived in New York City. She was right across the street from a hospital. So her and my father, they literally just walked across the street to the hospital. We went to the ER. My mother said, oh, I'm in labor. I'm about to have this baby. They said, oh, no, come back in a few hours. You're not ready yet. So she walked back across the street, went to the apartment. And she was like, no, this baby is coming. She's coming out. So she walked back to the ER. As soon as they placed her on a stretcher, I came right out. I was born right there in the ER, and everybody was shocked. And because I was born in the ER, my mother, she had no medications. She was given no oxygen. There was no monitoring. And then I myself, as a newborn, being born in the ER, I was exposed to lots of germs and diseases. So even at birth, I had to be separated from the nursery from other children because they didn't know if I had caught some type of germ or disease in the ER. So even, this is 41 years ago we're talking.
Mhm.
Black women have been experiencing this for decades, and still nothing has changed.
No, it hasn't. And it's not just isolated to Black women and pregnancy. There's so many biases in healthcare that just range from biases against Black people in general, as we could see from that clip with the young Black man who had seizures and was just assumed that he was drug sinking or had taken some drugs or something like that before we even really did an assessment to see what was going on. But there's also obesity bias, which is something that I have experienced with my family members.
Yes. You know, it's so interesting. I saw a clip also online just a couple of days ago. It was a meme and it was like a funny clip, but the lady said every time she goes to the doctor for an issue, they say, oh, that's because you're fat, so just go work out. And, you know, she was like, well, my arm is broke. Well, it's because you're fat. Or, you know, I have a stuffy nose. Well, that's because you're fat, so just go work out. And it's like, it was funny, but it rings so true to how often patients who may be overweight or obese are dismissed. And every health issue they have is, you know, related to their weight.
Right.
And that's dangerous. That's so dangerous.
It is. And it makes somebody who is overweight and obese very despondent. In my pregnancies, I had one pregnancy where I lived in Austin, in Texas, and I was seeing a doctor there, and all he did was just berate me and talk about my weight the entire pregnancy, postpartum. Oh, you haven't lost enough weight fast enough, and so it really, you know, you're flooded with hormones, number one, postpartum, and then to have somebody just, you know, you're not doing this good enough. You're not doing that good enough. And it was like, and I mean, I was eating really, really healthy. I was taking my baby and we were going out for walks every single day. And, you know, I really thought like, I'm doing a good job. You know, I'm breastfeeding, I'm doing all the things I was supposed to. And then to go to the doctor and it's just like, if you don't do this way, and if you don't do this that way. And it just really made me feel terrible as a person. And then when I was pregnant with my youngest one, I had a midwife who would give me goals. She's like, you know, she was very different in her approach. Same message, different approach, right? And she's like, you know, these are the risks that you run with being someone who is overweight and in pregnancy. And here's what we're going to do. We're going to set goals, okay? So between this visit and next visit, I want you to try to only gain, you know, 3 pounds or something like that, because we don't want you to gain as much weight as if you were somebody who was thinner during your pregnancy. Yeah. And that gave me motivation versus shutting me down.
Yes. Likewise, they told me for my body weight at that time, 10 to 15 pounds of weight gain was okay. Whereas somebody of a slimmer BMI, they could gain up to 30 pounds. And so that kind of put it into perspective. It didn't make me fear eating, you know, because that's dangerous to make a pregnant woman fear eating because of weight gain. Because during the pregnancy, we are supposed to gain a certain amount of weight so that we can have a healthy baby who does have a healthy baby weight.
Right. And then with my mom, we saw a lot of obesity bias with her. We would go to the doctor and she would, you know, say, you know, I'm having this or I'm having that. And it was, well, you need to lose weight. let's talk about weight loss surgery. And she's like, but that's not the issue I'm here for. I'm here for something else. I'm here for a sore throat. I'm here because I'm having an infection or whatever. And yes, obesity does put you at higher risk for a lot of things. And yes, those conversations do need to be had, but there is, a way to approach something. Again, going back to the example of my pregnancies, same message, different approach, right? And so had there been a different approach, my mom might have been more open to that. And as she got older, she experienced even more obesity bias. And one time she needed to have a I can't remember if it was a CAT scan or an MRI. And she was told by the radiology technician, you won't fit in our machine. You'll have to have this done at the zoo.
Oh my gosh.
Yes. And so these are the things that our patients are hearing.
That's unbelievable.
Yes.
Unbelievable.
And I had I not, had this not happened to me, I wouldn't believe this because this is not how I talk to my patients. But it is definitely happening out there where patients are being dismissed. Even she had a small bowel obstruction once, and they didn't want to do surgery because the risk was too high, and that would affect their numbers if she were to not make it off the table.
Yes.
So essentially they took the choice away from her, and they essentially just said, we're going to see if this NG tube works. Well, she can't live on an NG tube forever with no nutrition. So, I had to get a patient advocate involved, but I knew that those exist. I knew how to do that. I knew how to navigate. Being someone who's in healthcare and has been in healthcare for over 20 years, yes. I knew how to advocate and say, we need a patient advocate, because it is one thing for you to say, these are the risks and benefits of this procedure, and my mom to say, I don't want to have this procedure. That's a different discussion. Then we may be looking at palliative care at that point. But to not even give her the option to just essentially, sentence her to death because she's obese, that was unacceptable. It was unacceptable. It was completely unacceptable.
That's absolutely awful. That's so terrible. And so I'm just so glad that you're able to speak on this, because so many people don't know that these issues exist, and how awesome it was that you had the healthcare knowledge and know how to be able to advocate for her, because she surely would have died, because of that bowel obstruction. That's just terrible. And I'm so sorry that they said that to her, because that's just not right. The Zoo comment, that's unprofessional.
Very professional.
Absolutely. Yes. Well, we're going to go to our first break of the evening, but everybody stay tuned for more Pink Table Talk as we discuss the state of healthcare in Texas.
In a world filled with fleeting moments, there's beauty waiting to be captured. My name is Christian, and I specialize in immortalizing your most precious memories, from elegant weddings to vibrant events and timeless portraits. I'm here to make every moment unforgettable. Let me tell your story through the lens. Contact me today and let's create magic together.
Good evening, everybody, and welcome back to Pink Table Talk. Tonight, we're discussing the state of healthcare in Texas with Serena Tobar. So, Serena, how would you describe the current state of healthcare in Texas right now compared to the rest of the country, in your own opinion?
I think right now in Texas, it's good and bad. And I think we have a lot of strong, very smart nurses in Texas. We don't come together as one. So that's part of the problem. And when you look at healthcare, especially in more rural areas, because it's happening even in Houston, in a very urban area. It's happening in Dallas, in a very urban area. But as you even get into more rural areas where there's less choices of who your healthcare providers are, you're going to see more and more biases and more people with bad outcomes. And again, it's not just racial biases, it's obesity biases, it's gender biases.
Yes.
Right? It's sexual orientation biases.
Yes, absolutely. Yes. You and I, we collaborated together on a research article that talked about the bias in healthcare for the LGBTQI plus community. In that, we discussed how even the questionnaires during intake can be biased towards people of that community. Tell me more about that.
So when you're looking at some of the questions that they're asking, and we whether we agree with what somebody identifies with or not is not, it's not important, right? Because we're not the one that is receiving the care. And if you are a nurse, at some point in your nursing curriculum, when you were in nursing school, you learned about how healing is mind, body, and spirit.
Yes.
Right? And whatever we believe personally, it doesn't matter when you're caring for that person who doesn't believe the same way that you do, whether it is a religious belief, whether it is about their gender identity,
correct,
whether it is about their sexual orientation. That's still somebody. And I know a lot of people say, well, that's somebody's aunt, uncle, mom, dad, son, daughter. But at the end of the day, it's somebody, regardless of what relationship they are to anybody else. And so when you look at those biases, and we have to take a step back and think about our own biases and say, okay, maybe I don't agree with this, but that's not going to affect the care that I give today. The care I'm going to give today is still going to be superior. This is still a person. And maybe they don't believe the same as me, but like I'm a Christian. I believe in God and Jesus. But if everybody was the exact same, what a boring world we would live in. Right?
Yes.
Absolutely boring. And so many good ideas would be missed out on. And we'd probably still be in like the caveman days, like banging sticks on rocks and whatever, because how can we evolve as a society if everything is the exact same and everybody's the exact same and there's no differences? So those differences are what make us so special. But again, when you look at especially the LGBTQIA community, and you look at those intake questionnaires, and you have to pick male or female, and maybe somebody doesn't identify as either one of those. And a lot of times there's not, the sexual health questions aren't appropriate, right? And so we really have to look at all of those things, even racially. I don't think that we are capturing, because when you look at race, what race do you pick, right? You got, white, black, Hispanic. Okay. Some people don't fit into any of that box, right?
Yeah.
They go to other now, right?
Yeah, what is other?
So you want me to just choose one thing, but that's not who I am. So how do I choose? What if I am biracial, white, and black? Do I choose white or do I choose black? Maybe I choose white, but you don't agree with that because you say, well, my skin's too dark to be black. But maybe I say that I'm white because I'm half and half. You know,
Yes.
you made me pick one. That's the one I picked. Right? Or maybe I pick black and I'm too white and you don't think I should pick black. But you made me pick one. And really I'm both.
It's so true, you know, and I think you speak on a great issue here. You know, a lot of us don't fit into a box, you know, and I feel like a lot of the times with those questionnaires, and I understand for research purpose statistics, they have to collect these demographics. However, they're so limited, you know, and so that does create a bias. You know, if someone identifies as, let's say, binary or trans, or like you said earlier, biracial, where is that? It's not there. And I think that to be inclusive, we need to start opening up those other options for people so that they can feel included, they can feel seen and heard.
Mm-hmm. I recently met with somebody at our doctoral colloquium for my school, and she is I think she said she was Puerto Rican, and her husband is he's a black man, and her children are very fair skinned. So they're lighter skinned. They look more Hispanic than they do black. And her son was having some constant issues, and they were trying to go back to the doctor, and she finally said, hey, we should test him for sickle cell. And they were like, oh, but he's Hispanic. He doesn't need that. And she's like, but no, it was her dad. Her dad is black. She's like, but my dad is black.
Yes.
And therefore I'm a carrier.
Yes.
And it could have gone to him, even though he's so fair skinned.
Yes. Yeah.
Right. And so we have to think about those kinds of things. So when we put those biases in place and we try to fit people in a box, you may have somebody who's my skin color coming in, and they could have sickle cell because somewhere in their genetic history, you know, they have somebody who is African descent. And so that's the danger of trying to box people in, is we're going to miss things.
So true. It's so true. And you know, it's so funny with like the 23andMe, people are now able to get more clear genetic history on themselves. And so recently my mother did hers, and she found out she's part Ashkenazi Jew. And so I said, so then that means you need to test for the BRCA genes. And so she, you know, a lot of people, because she's very dark skinned, you know, she's African American, they wouldn't think to test her for that gene. But 23andMe says otherwise.
Right. Right. And again, that's part of the bias of healthcare, is we try to say, well, if you're black, these are the things that should be wrong with you. And if you're white, these are the things that should be wrong with you. And we're going phenotype, right? So if we talk about phenotype versus genotype, phenotype is how genes are expressed. So this is what we look like. So if you look like you're white, I'm only going to look for white people diseases. If you look like you're black, I'm only going to look for black people diseases. And so again, there may be Mediterranean in there, and we're not looking at, because all I see is what I see is a black person. That's a bias. Yes. Because I'm not digging any further. I'm just saying, you look like a black person. So in my head, I've made you a black person.
Yes. And it's so dangerous when we do that, because we could be missing so many diseases and disorders. You know, there's so many genetic diseases that could be passed down, even if it was generations away. You know, somebody from your great grandfather's line, you know, could have passed something down that now shows up. And so when doctors or physicians dismiss patients based on their symptoms because of the way they look, it's very dangerous. And that's going to lead the door to a lot of illnesses not being diagnosed or properly diagnosed, as well as delayed treatments.
Exactly. And again, a lot of that can go even back to those intake forms where you've made me choose one box. I had to choose one thing.
Yeah.
And so I chose the thing that I feel like I most identify as.
Yeah.
And so now you've boxed me into that. And so we're only going to look at things that could possibly be related to that. And we're not going to look at the other aspects of my hereditary, or my genotype, what makes me me.
Yes, it's so true. And then going back to the LGBTQI plus community, there also are not being screened for a lot of diseases as well. They're missing a lot of cancer screenings, a lot of PAPs and prostate cancer screenings, as well as STD panel screenings. Because those questionnaires are so limited. So, they might answer one way, and so the doctor may not order certain panels of testing because of the questioning. And so I think that we need to start looking more into how to better treat people of all genders, all ethnicities, and of all communities. We have people suffering out here. And so I think we need to create a more diverse healthcare system, not only here in Texas, but across the nation.
Yes, for sure. People are more comfortable when they see people working in the hospital that look like them. If everybody looked like me, right? Would you feel comfortable going to hospital for your care if everybody looked like me? Yes. Right? Because how can they relate to you? Because we all have biases, whether we want to admit it or not. We have biases. I have biases. You have biases. Everybody has biases because that's just, it's ingrained in us, all of us, because we were all raised differently. We all believe differently. So we are going to have a little bit of biases. It's how we handle those biases and acknowledge those biases. And, again, going back to the LGBTQIA community, sometimes people are afraid to say that they are LGBTQIA because the assumption and the stigma around that is, oh, well, they must have a sexually transmitted disease. They must have multiple partners. They must have, and I know plenty of people who fall within that spectrum, and they are very monogamous. They are married. They're happily married. They're raising children. Just because somebody identifies as gay or a lesbian does not mean they're out there having these huge orgies. I don't know what people think, why people think that's true, right? And then the opposite can be said of heterosexual couples. Sometimes people think, oh, well, this is a heterosexual person. And they may not necessarily immediately think of a sexually transmitted disease.
Exactly. And married women are one of the number one populations that are coming down with HIV and AIDS infections because they're not being screened, because it's back again to the questionnaires. Oh, are you in a monogamous relationship? Just certain questions. They're not going to test them. They're not going to test them for these panels, and they should. They should still. They should. Yeah. So that's very dangerous to do that.
Mm-hmm. And just because the woman or the man, just because one side is in a monogamous relationship doesn't mean the other side has been monogamous.
Are you monogamous?
Right. So again, we're making assumptions. We're having a bias because we're saying, oh, this person's married. They're in a monogamous relationship. So they can't possibly have an STD, right? They've been married for 10 years. Has their partner been faithful?
Correct. So, and we know that there's so many variances, and so we just need to be open to all possibilities. So please test them.
Yes.
We're going to go to our second break of the evening, but everybody stay tuned for more Pink Table Talk with Serena Tobar.
Join us for a captivating new series where Lawin sits down with the trailblazers of the music and entertainment world. Discover the stories behind the faces and voices that shape our culture and community.
We will bring you exclusive interviews with industry legends and rising stars. Behind the scenes insights and get a peek into the creative processes and personal journeys. Artists and performers and their upcoming shows and events.
Stay tuned for more updates and sneak peeks. Follow us on social media and subscribe to our channel. Filing taxes, dealing with tax debt, or facing IRS actions is stressful, but you don't have to go it alone. Call 832-674-0829 or visit www.taxresolutionesq.com.
Good evening, everybody, and welcome back to Pink Table Talk. The show is produced by Lawin Media Network, and you can catch us live every Wednesday at 7 o'clock Central, 8 o'clock Eastern. You can catch us on YouTube Live, Facebook Live, Twitch TV, and all podcast platforms. Tonight, we're talking about the current state of healthcare in Texas with Serena Tobar, PhD candidate at Texas Women's University, as well as legal nurse consultant. So, Serena, currently, how do you see socioeconomic status, race, and immigration status affect access to healthcare here in Texas? What is your opinion on that?
Well, we already see that even before the current climate politically with immigration, we already saw that immigrants were less likely to seek medical care.
Yes.
And then we added the question on intake is essentially, what is your immigration status? Are you a legal citizen? And so that made them even less likely to come and receive medical care. So they're trying to self-treat. They're trying to use old remedies that have, passed down through generations, and they're not getting diagnosed. They're dying at early ages. They're dying from very preventable or very treatable conditions.
Yes. And it's so hard to see, because we opened our doors as a country to allow people of all countries to come here for refuge and for a better life, for the American dream. But they're suffering medically, they might go to the ER for certain things, but then there's long waits. They're not being treated fairly. And so then also it's putting a burden on our system, because if they don't have health insurance, it ends up being put on the hospitals, the city, and tax dollars.
Right. And a lot of lower socioeconomic class they use the emergency room as their primary care. Yes. Because they know they at least are going to get a medical screening, right? Because that's the law. Yes. But if our healthcare system was set up differently, and we treated the lower socioeconomic class like human beings, then they would have the opportunity to be seen by primary care, right? Yeah. To be seen in an outpatient setting and not fill up our emergency room with their primary care needs, right? Because they're going in for things like, high blood pressure, ran out of blood pressure meds, I need a refill. They're going in for things like uncontrolled diabetes because they ran out of their medicine, they haven't seen their doctor. It's been, 6 months since the last time they were in the hospital, and they used up that prescription they got from the hospital, and that was it. They didn't have anybody to follow up with because they did, a lot of these people have to choose. Do I pay my rent? Do I put groceries on the table? Or do I go and see the doctor? Correct. And if you have to go to the doctor and the doctor costs you $150 for a visit because you don't have insurance, that's a lot of money.
Yeah, that's a lot. And a lot of people can't afford it, and they're going to choose to wait, go with the sickness or the injury, and try some home remedy, like you said. And that's so dangerous for them, and that's putting a lot of people at risk. And as well, people are dealing with injuries that also make it impossible for them to work. And so then, like I said, it's a cyclic system. So then you have people who are out of work and people who are sick, and then they can't afford health care. So, the cycle will just continue because of that.
It just continues. And there are clinics and stuff out there that do their best to try to serve the population. The population is just so large. There's only so much that can be done. And when you think about our veterans, number one, my sister is a veteran, and when she has to go to the VA, that's almost an all-day thing. She has to take a whole day off of work. And luckily, she works a job where she has PTO and she can use PTO to be able to go to her doctor's appointments. Some people don't have jobs that afford them PTO where they can take a day off and go sit all day for a doctor's appointment. And so if they don't go to work, they miss that day's pay.
Yes.
Right? Yeah. And so sometimes people are choosing, like, if I don't go to work today, I'm not going to get paid. If I don't get paid for today, I'm not going to be able to put food on my table. And so they choose to continue to be sick and continue to go to work until, again, that's that cycle that never ends until they end up in the hospital. Then they have to take off work, right? They get out of the hospital and the cycle goes again, because we're not set up, if you have to sit there all day, and then how often, because when you go to the doctor, then they want to refer you to this specialist, and then they want to refer you to that specialist. And then before you know it, you're going to the doctor 4 or 5 times a month. And some people can't afford to take that off. Some people lose their job if they try to take off 4 or 5 times a month to go to the doctor.
It's so true. It is so true. I remember once I was up for jury duty, when I was in college. And one of the excuses potential jurors said, well, if I missed 3 days of work, that he was going to lose his health insurance. And so I thought it was quite odd to me. And even the judge said, well, what kind of work do you do? And he was a waiter. And I said, okay, so that does make sense. And so she didn't choose him to be on the panel. But it made me think, and I didn't know that, as a young woman in college, I didn't know people could lose their insurance if their hours were cut or they missed a few days of work. So it was quite interesting that that's a phenomenon that does occur here in this country.
Mm-hmm. Yeah. I mean, it can happen even in big organizations. If you don't work the amount of hours that you're supposed to work, then you could lose your health insurance, because your insurance is being paid based on, it's kind of like saying, well, you're going to work this amount of hours and I'm going to pay for your insurance. But if you're not giving that full amount of hours, well, they're not going to pay for your insurance anymore. And waiters, perfect example of what I was talking about. If a waiter doesn't go to work, that's no tips, no money for that day. Yes. And we see waiters work really hard.
Yes.
They work really hard. My daughter's actually a server. I know how tired she can be at the end of a long shift. It's very demanding. You're on your feet all day. So it is a lot. And people work these jobs and they cannot afford to miss a day of work.
No, they cannot. And it is sad, because people have to make that choice. And this is part of why COVID-19 was so widespread, was because people had these symptoms, but they still went to work. Mm-hmm. And it's sad that it took a pandemic for organizations to give their employees sick time. And I think it was the first time where it legally became a requirement for big organizations to give at least, I think it might have been 16 or so hours at the least for sick time. I said, how did they not have sick time before? It was quite shocking to me.
Mm-hmm. Even as a nurse, I've worked jobs where if I didn't work that day, I wasn't going to get paid for that day. I did home health for a long time. So if I was sick and I didn't see my patients for that day, that means that was a whole day I wasn't going to get paid for. So I got paid by the visit. So it's not just, when you think of what's going on out there. You know, people want to say, well, you know, you should work harder, you should go to school, you should get a better job.
Yeah.
But there are people out there who have what is nursing is considered one of the most trusted professions, right? If somebody says, oh, you know, if I tell somebody I'm a nurse, that's so great. But I was even in a position where I didn't have health insurance provided by my company. I didn't have, you know, if I didn't see my patients for that day because I was sick, then I wasn't getting paid for that day.
Yes, it's so true. It's so true, especially for agency nurses. A lot of people don't realize, but agency nurses, like the people that kind of fill in temporary or travel, they don't get health insurance. And certainly not before COVID. I think now there might be some premiums they can buy. But prior to COVID, a lot of agency nurses, they didn't have health insurance.
Yeah. It's just, again, when you think about how people think the answer is so simple, and it's not. Yeah. It's not just go get a better job. It's not just, we'll go to school. Well, if I go to school, who's going to feed my family, right? Number one, because if I'm at school, I'm not going to be at work. And number two, who's going to pay for me to go to school? Because you don't want me to take a student loan, right? Because we made that abundantly clear. We don't like people who take student loans. And then we don't like people to go to college because colleges just make you all, you know, they infiltrate your mind into what they want you to be. And so we don't want people to go to college, but we want people to get better jobs. So we tell people to go to school to get a better job because we don't want them to be waiters, and we don't want them to work at McDonald's, and we don't want them to work at Walmart. They should get a better job. Okay, but if nobody works at Walmart, there's no Walmart.
Yes.
If nobody works at McDonald's, there's no McDonald's, right? So McDonald's, you know, you can't just say, oh, that's for teenagers. Who's running the McDonald's? It can't be a 16-year-old. Somebody's got to run it. Somebody's got to be in charge, and that person has to be an adult. And so at the end of the day, we kind of stop looking and being biased on what somebody's career is, because at the end of the day, that is filtering into our healthcare system, and it's affecting how people are getting treated and how they're getting access to healthcare.
Yes, yes, so true. We're going to take our last commercial break of the evening, but when we come back, we're going to talk about that legislation. So stay tuned, everybody.
For divorce and family law in Texas, Liggett Dizon Law Firm PC will guide you every step of the way.
From initial consultation to detailed review of your case and strategic planning.
We'll sit with you during negotiations or mediations, and represent you in court.
Whether it is a family law, estate planning, or immigration, we will be there to guide through the final steps.
So, leave your legal matters behind you and embrace your future.
You can contact Liggett Dizon Law Firm PC at 346-5454-346 or visit DizonLawFirm.com.
Good evening, everybody, and welcome back to Pink Table Talk. Tonight, we've been talking about the state of healthcare in Texas. So, Serena, my next question for you is, what legislation or policies do you think should be prioritized during the next elections for Texas?
So I think definitely during the next legislative session, we really have to look at, number one, if we want to increase access, we definitely need to look at getting our nurse practitioners independent practice.
Yes,
that's going to increase. That's going to increase the access to healthcare. It's going to make it where it's more affordable, because nurse practitioners is cheaper than a doctor, right? And so if I can go see the nurse practitioner for $40 versus the doctor for $100, then I'm going to go see the nurse practitioner. So we're going to increase access. You know, a lot of what's keeping nurse practitioners from being in their independent practices or being out there in the with the public in primary care is the fact that they have to pay sometimes very exorbitant amounts of money to doctors to supervise them. And so we have been trying for multiple legislative sessions to get this passed, and a lot of it is, just I hate to say it, but it's the good old boys club where doctors don't want to give it up. They don't want nurse practitioners having full practice authority. And so if we can start with there, we can increase access to healthcare, and we can make healthcare more affordable for patients to be able to get to.
Absolutely.
The second thing we need to look at is this new, I don't know if it's a policy or if it's a law. I need to do a little bit more research, but there is something out there right now about how advanced degrees in nursing are not being considered professional degrees. So that is going to keep people from pursuing those nurse practitioner degrees, right? So we're going to have less nurse practitioners if they are not able to get the loans to pay for school, because not everybody has that kind of money laying around to be able to go to school. It's very expensive to get a master's degree. It's not free. And so we're starting to do this. We would lose our nurse practitioners and our PAs. Right. And so when you're looking at that and you're saying these are not professional degrees, I wholeheartedly disagree with that. These are very professional degrees. So you're not going to have master's or doctorally prepared nurses, which is really going to hinder not only access to healthcare, but the quality of care that patients receive.
Yes, absolutely. And I 100% agree with you. When I read that the other day, I was absolutely shocked. And I know the American Nurse Association, they wrote a impact statement, and it was just so touching, because it's like, how did we get to this point? Nurses have been considered a profession for so many years, and the advancement of the nursing practice with those degrees is part of our progress. It's part of us helping to translate research into practice. It's helping us to improve patient care and quality of patient care. And I myself, as a doctorally prepared nurse, I see the difference. And I worked very hard for that degree. And now I'm able to teach, and I'm able to do evidence-based practice and to do speaking engagements to help improve practice and to improve care. So them trying to get rid of it as a professional degree, to me, it's just another jab to keep nurses out of, like you said, the boys club. It's to keep nurses and nurse practitioners from being seen as equals to physicians, from being able to make decisions, to be in the front line of the government, to put in policies into practice that will help healthcare. So to me, I see it as a step down, as them trying to hold us back.
Right. And nurse practitioners, they're not trying to replace doctors.
No.
You're not going to have a nurse practitioner out there doing surgery, right? You're not going to have a nurse practitioner that is going to be the expert in cardiology, who's going to be the consult or whatever. Nurse practitioners are just trying to say, let me work alongside of you so that our patients can have more access to care.
Yes.
More options.
Yes.
Right?
And they fill the gap. They fill
the gap. Yes. Fill the gap. That's what they're trying to do. They're trying to fill the gap. And if we can, switch that thinking from that, and like you said, you're doctorally prepared, so now you teach. And if we don't have master's degree or doctorally prepared nurses, who is going to be the people who prepare our next generation of nurses? And what does that mean for healthcare? Because we're already in a nursing shortage. We're already in a nursing faculty shortage. So what is that? How is that going to impact our patients and our patient outcomes?
Yes, and the nursing shortage in general. We're still facing a nursing shortage crisis that's only going to worsen in 2030. And like you said, we have a faculty shortage. And so if people know that pursuing a higher or an advanced degree, they're going to have to pay out of pocket for it, they're not going to pursue those degrees, especially degrees in education. You know, they're going to opt for a more affordable degree that they don't have to worry about paying for. And so that's going to lower the field. That's going to make it harder for us to find people to fill in those positions.
Yeah. Yeah. And when you're with your PhD prepared nurses and your DNP prepared nurses, you know, this is where you're doing research, right? So your PhD nurses, that's what they do. They're out there doing research to see how can we get number one, how can we get patients better access? That's some of the research that I've been seeing with some of my PhD candidate colleagues and those that have defended their dissertations already. A lot of it is around access to care. A lot of it is around, you know, how do we use technology to better patient outcomes? It's all about patient outcomes in the end, right? Whether we're getting them more access to care or whether we are looking at how do we develop our nurses to provide the highest quality care. This is all research that's important, because if I'm the one sitting in that hospital bed, I want the best possible care because I want to go home.
Absolutely, absolutely. And we need better quality care. You know, we need to see more improved health outcomes. The nation is sicker than it's ever been before. We're seeing people with much more chronic diseases and illnesses. And like we said, with the lower access to healthcare, people have delayed treatment. So they're coming in work. And so how could we as a profession treat people if we don't have the advanced education and degrees?
I totally agree.
Yes. And so before we end, I know you shared with me your own personal story of healthcare and how you've been treated here recently with the hormones. Talk to us about that experience and how you found
yes.
it. Yes.
Yes. I completely forgot about that. But yes, you know, even, you know, being a woman of a certain age, I started having some symptoms. I was having just horrible brain fog where it was just couldn't concentrate, couldn't remember things, really having like almost like ADHD type symptoms. My ears were bothering me so bad. Like I was ready to see an ENT and just figure out why my ears are bothering me so much. They were just itching all the time and it's just bothering me. And I would go to the doctor. Oh, your ears look fine. There's nothing there. There's no infection. There's no wax. There's nothing. And I'm like, but my ears are bothering me. And the insomnia was so, I'm just tired all day. And then I could fall asleep really fast. But the problem was I was only being asleep for like 20 or 30 minutes, maybe an hour. And then I'm up. And then I might fall asleep again for like 20 or 30 minutes. And then I'm up again. So the insomnia was crazy. And going to the doctor and saying, these are my symptoms, you know, and it just, oh, well, maybe if you lose some weight, the symptoms will improve. Let's talk about a weight loss plan. Okay. Yes. I will talk to you about a weight loss plan, but being overweight is not making my ears itch. Being overweight is not making me not sleep. So I finally was talking to some of my colleagues and they were like, Serena, this sounds like perimenopause. So she sent me to, number one, I'm mad at all my aunties and everybody else who never told me about perimenopause. There was just you are all the way. And then there was menopause. There was no perimenopause. So I didn't know there was such a thing, but that goes to tell you the how behind we are in women's health and understanding what women go through, because women were just told there's nothing wrong with you. And, you know, they're still having their period. So they're not in menopause. So there's nothing wrong with you. And so I saw a specialist, and now I'm on some hormones, and those symptoms have all but resolved. And it's just, I can sleep now. I'm not as fatigued. I can concentrate. My ears are not itching. Now, I don't know how to keep these little boogers in there where they don't fall out, but I promise they haven't been itching. But it's just when I talk to the specialist, and she's telling me, yes, we treat the symptoms, because what happens is you can draw the hormone levels, but if you're still having a cycle, your hormone levels are still fluctuating. And so that's not necessarily indicative of what's going on with you. And she's like, you can very much be in perimenopause and still have normal hormone levels.
Wow. Interesting. And see, that's such a great story, because I feel like a lot of women in our age group are going through that. Definitely know I'm feeling some hot flashes.
Well, and I've had doctors, afterwards, they're like, oh, well, why are you on estrogen? Why are you on progesterone? I'm in perimenopause. They're for my perimenopause. Well, you're only 44. You're too young.
Yeah.
Well, please tell that to my body, who's this hormones are, making everything better. So tell that to my body, because obviously my body did not get the message.
Well, the statistics do show women are going into menopause a lot earlier these days. And so, whether it's environmental or, whatever, but this is a phenomenon that is occurring. And so they need to take it serious, and they need to address it. And so I think that's also an age discrimination bias.
Right.
So
yes. Yes. And when like a 24-year-old is telling you, 24-year-old nurse practitioner is telling you you're too young to be in perimenopause, you just kind of look at her.
But there have been cases of women early 30s going into menopause. And so, yes, we can't just look at the age and assume that they are not. So very, very interesting. Very interesting.
Yes. And this is why we have to listen to our patients.
Yes.
And stop making assumptions and stop being biased. And we have to look at our patients as a whole and listen to what they're saying.
Yes. And there's a duty to care, for physicians and for nurses. There's a duty to care. There's ethical obligations that they have to follow. And then there's the overall belief of benevolence, it's to do good and to not cause harm. And so I feel that if physicians and nurses here in Texas took that to heart, they will treat patients better, and we can see an improvement in the state of healthcare here in Texas.
Exactly.
Thank you so much, Serena. This has been an interesting conversation, very informative. I've absolutely enjoyed it. So tell us more. What's next for you? And tell us about your new podcast that you started.
So basically what's next for me is finishing up this dissertation so I can get this PhD. But yes, I do have a podcast. It's called Why We Nurse Podcast. And unfortunately, there is a lot of negativity out there, and this is one of the times, that clip that we saw at the very beginning of your podcast. It shows a negative side of nursing, and so I want to show a positive side. And so what I do is I talk to somebody each week. We talk about their role in nursing and how that role has shaped their view of nursing, and just some different, different things that, in different aspects, so we've talked to a legal nurse consultant. We've talked to an endoscopy nurse. We've talked to residency coordinator, nurse manager. We've talked to somebody from the OR. We've talked to a nurse resident. And so it's all about looking at, what keeps you coming back every day to nursing, because it's not always a thankful career.
Yes. And I'll be on your show this Friday night, November 21st at 6 p.m. So I'm looking forward to it. I think it'll be wonderful.
Yes, we're excited to have you.
Thank you so much. And thank you again for joining us tonight. I'm wishing you luck and all your future endeavors and on finishing up that dissertation. I can't wait to call you Dr. Tobar.
Thank you. Thank you. I will be so happy when it's done.
Yes, absolutely. We'll have to celebrate. Well, thank you everybody for tuning in tonight. You can catch us live every Wednesday on Lawin Media Network, either through our YouTube, Facebook, Twitch TV, and all podcast platforms. Remember, on Wednesdays, we talk paint. Thank you so much for tuning in tonight. And be sure to catch out Serena's show, Why We Nurse, on Friday, where I will be the guest speaker this Friday, November 21st. Have a good night, everybody. Bye-bye.